Hello, everyone. This is Siddharth Damber, Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today on regenerative medicine. So today we are talking about regenerative medicine. I'll talk for roughly 20-30 minutes. Please enter your questions into chat as we're talking, and I'll catch up on questions and answer as we go along, and I'll leave plenty of time at the end as well. So what you'll get from this webinar is the following. You'll learn about the best available treatments for arthritis and tendinitis that do not require surgery, what is legitimate and not legitimate in the field of regenerative medicine, and how to choose the best physicians and clinics for your regenerative medicine treatment. And if you'd like to learn more after we're done with our discussion today, you can always go to chicagoarthritis.com. So the big question is, what would you do if your pain was controlled? How would your life improve? What exercises would you restart? And what activities with family and friends would you participate in? So a bit about who I am. Again, my name is Siddharth Damber, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist in image-guided musculoskeletal injections, in practice since 2008, involved in regenerative medicine since 2008, and part of the Regenix network, which is the largest network of physicians who are connected and sharing protocols and results and best practices since 2012. So my personal journey into regenerative medicine really starts with my own shoulder. I used to play quite a bit of tennis when I was younger. In my medical training, I learned how to do musculoskeletal ultrasound. At that time, I recognized that I had a small injury to my rotator cuff. I didn't have any actual pain, but it made me start realizing that there's aspects to tendon and ligament injuries that really were not being appropriately evaluated for most of my patients, and they were not being appropriately treated. So it got me looking into how to treat these kinds of conditions better, not only treating my own injuries and ailments, but also friends and family members, and then eventually also patients as well. So traditional care for musculoskeletal issues, that's whether you're talking about tendon problems, ligament problems, arthritis, or spine issues, is essentially to mask the pain and eventually waiting for some kind of major replacement surgery. It's a really terrible way to treat things because we don't do that with other parts of the body. Meaning, if you have high blood pressure or diabetes, we don't wait for you to have your first severe heart attack before we treat it. We try to treat that more proactively, at least nowadays. So the problems with traditional care, at least for musculoskeletal health, are pain medications don't fix the problem. They have tons of side effects. Traditional injections, such as steroid injections and nerve blocks and radiofrequency ablation, can give pain control, but again, they have a lot of potential side effects that are not really good for you long-term. Surgery appropriate in some cases that are more extreme, but it's higher risk. And if there are options that are less risky, we should always consider those. Number two, a lot of routine surgeries like knee arthroscopy, if you've already had arthritis, really just accelerate the arthritic process. They lead to more instability. And many routine surgeries, such as knee arthroscopy, if you've already got arthritis, have been proven not to be effective. So for those of us who are involved in this kind of medicine, we generally feel that 80% of musculoskeletal conditions that have been treated with surgery can likely avoid surgery long-term. In the same way that the vast majority of things that used to be treated with open heart surgery are now treated with medication or needle-based procedures, we do feel that a lot of orthopedic surgery can go the same way. So in searching for better options, these options should be low risk and avoid serious side effects. They should be lower risk than the other options, such as surgery. They should address the source of the problem that includes instability and inflammation or metabolic issues. And they should improve the actual cause of the problem, which again is instability and inflammation. And it should give you longer term improvement than what we can do right now. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the process where we utilize your own body cells to treat arthritis and tendinitis, injuries, and back pain. The normal healing process, you have the following. Take something as small as a cut on your finger. You have platelets that enter the area. They first stop the bleeding. They then release growth factors, which then stimulate your own local stem cells. Then through a process of inflammation, bringing in other cells, and eventually repairing that tissue, there's a healing process that happens over time. This works well for tissue that has good blood supply. For tissue that has poor blood supply, that includes tendon, cartilage, ligaments, disc, labrum, and meniscus, tissue tends not to heal very well on its own. So regenerative medicine is a process where we take those same cells that are involved in healing, such as your own blood platelets or your own bone marrow stem cells or your own stem cells, and then injecting that under high-level ultrasound or X-ray guidance to then start the normal healing process. So again, why regenerative medicine? We can treat instability, we can treat inflammation, really the sources of the problem. Safer than surgery, effective for most musculoskeletal conditions, and again, really should be the dominant way of treating the vast majority of musculoskeletal issues rather than surgery in the future. So how does regenerative medicine work? Talk a little bit about it, but essentially we're optimizing damaged cellular health of tissue. We're improving the strength and stability of the supportive soft tissue around a joint. We're reducing chronic inflammation, improving neuromuscular health. By optimizing the tissue, you're improving the actual health of the tissue and the joint and the tendons. That's what gives you pain relief. Improving stability, what gives you better functional improvement. That all combined, optimizing the overall tissue is what gives you better function, pain relief, and quality of life long term. It's a very busy slide, but what makes a regenerative medicine expert? There's a lot involved in this. It's really its own field of medicine at this point. Number one, your physician and clinic, they should be musculoskeletal experts. And what that means is that they should be focused on joint health. They should not be treating blood pressure in one room, treating somebody's, giving Botox in the next room, and then injecting your knee. That's not an expert. That's not how medicine works. Medicine works where you should be a deep expert, where that's all you really focus on day in, day out. They should be a non-surgical musculoskeletal expert. My surgical colleagues are very good at surgery. That's what they're trained in. They don't have the appropriate training when it comes to image guidance for doing these kind of procedures properly. So they should also be an image guidance expert when it comes to these procedures. Why is that important? A lot of my colleagues who are a little bit older tend to see that they can do some of these injections just by blindly palpating the skin. The reality is, and I'll show you some images later on, that when you want to do these treatments properly, you can't just be close to the tissue. You have to be really down to a sub-millimeter level when you're injecting cells. Otherwise, you don't get the right kind of effect. They should understand how inflammation helps you heal. I have colleagues who they'll give steroid injections, and then they'll give these kind of treatments. It doesn't make sense. The steroid injections nullifies what they're doing. If they don't understand what meds you need to hold or stop before treatment, again, that's a key part of making sure that inflammation is helping you out. They should understand the different types of biologic treatments that are available, and they should give you a personalized or bespoke treatment plan rather than a one-size-fits-all treatment. I'll give some examples of that. But if they're only saying that here's how we do things, it's only one way, and they don't understand that the actual cells that you use and the prep that you use can be specifically modified in a way that is specific to your problem, that's different than somebody else's, then they're not really an expert. They should understand the concept of prolotherapy, which essentially means that we're treating instability. Again, I'll show you examples in a moment. They should understand, or they should be transparent regarding the results that are possible with treatment and really your candidacy for treatment. They should be able to follow your results long-term. It shouldn't just be doing a procedure and then never seeing you again. And again, they should be able to answer your questions and guide you through treatment. Other really common questions that we get are, is this legal from an FDA standpoint? 100% if you're following the rules. So the rules are really threefold. Number one, are you using your own cells? You can't use somebody else's cells. You have to use your own cells. Number two, are you treating a musculoskeletal problem? If you're trying to treat somebody's heart problems or autism or stuff like that, that is not legit. In the world of regenerative medicine, is not legal from an FDA standpoint. It has to be for musculoskeletal health. And then lastly, it has to be, if you've had your labs drawn, they're being prepped, it has to be used the same day from a safety standpoint. Another common question is, if I'm older, should I use someone else's cells? Absolutely not. So for the vast majority of orthopedic conditions, there's very good evidence that using your own cells is not only effective, but it's also what's safe. Using somebody else's cells adds in the possible issues of graft versus host response, meaning your body responds to somebody else's cells like it's foreign tissue. So you want to use your own cells. Is there an age limit? No, the vast majority of what we do, there is no age limit. The one exception to that are hips, where the outcomes can be worse if you're older than 65 or 70 years of age. So what sort of doctor does these treatments? I talked about this a little bit, but they should be a specialist and focus on musculoskeletal conditions. They should be focused on non-surgical treatments, and they really should have all those other qualifications that I mentioned for a regenerative medicine expert. So can these treatments help if you've already had surgery? Simple answer is yes. The exception being that if you've had a joint replaced. So if you've got metal or plastic already in the joint, we can't really do anything about that. But if you've had, let's say, an arthroscopy surgery, we can still help for sure. My general rules for orthopedic surgeries are try to keep your anatomy, avoid surgeries that are only cutting out tissue if possible. Always consider a regen med treatment option if you've been recommended surgery. So there's a number of key concepts when it comes to regenerative medicine, which we'll talk about. Stability is unbelievably key. In the world of architecture, there's this concept of tensegrity. What it means is that if you take individual structures that are weak on their own, if you put them together and under compression, you get a much stronger unit overall. So biotensegrity is the same concept when it comes to medicine and science. So prolotherapy is the idea of taking your own cells, injecting them into the soft tissue structures around a joint, leads to an overall stronger structure, which then leads to better pain relief and function long-term. So there's this concept of layers and depth of treatment. So the idea is that if you take a joint, let's say a knee joint, you're not just treating the joint. You should not only be injecting into the joint. You should be treating every level of that beforehand. That includes the skin, the subcutaneous tissue, the myofascial tissue, the ligaments, the tendons, the muscle, and then eventually the joint as well. If you treat all those layers of tissue, you get a much stronger response and a much stronger improvement over time. And that gives you a longer lasting effect over time as well. It's an example of a 71-year-old man who'd had prior surgery before, laminectomy surgery, still having pain, very common. We see patients who've had prior surgery for their back and they still have pain. So in his case, we ended up using his own blood platelets originally. We treated his ligaments, the muscles, the facet joints, and the epidural space, all the different relevant tissues that are involved. His initial improvement was mild, 30% with his own platelets. We ended up escalating to his own bone marrow stem cells. He's now up to 75% improvement. The keys there are, number one, treating all the different levels of dysfunction or what can lead to pain. And then also that if one treatment option, such as platelets, gives you some relief but not enough, escalating something stronger can still be very helpful. So that leads me then to this concept of orthobiologics. Orthobiologics are essentially the cells and tissues that we inject into damaged musculoskeletal tissue. Again, this utilizes your own normal healing process, and please use your own cells, not somebody else's. The first line treatment you want to understand are platelets. So as I mentioned, after an injury, platelets are the first cells that are brought in to stop the bleeding and start the normal healing process. They work by stimulating your own local stem cells. And they work by causing inflammation. Inflammation, when it is acute and healing from an injury, is normal. Inflammation that's chronic, that's causing you pain every day, that's problematic. And we can treat that as well. So there's different types of platelet preparations. And that's important to understand because one size does not fit all. All right. Depending on what your problem is, we may use a high concentration of platelets for a joint. We might use a moderate concentration for a tendon problem, or we may take a type of platelet called platelet lysate, where we actually take your platelets, crack them open, and just take the growth factors. That's better for ligaments. That's better also for nerves as well. The picture on the right are two different types of platelet preparations. The one on the right that's more red, has more red blood cells, causes more inflammation. Okay for muscles, not really so great for joints and tendons. The one on the left side are platelet-rich plasma, where we've gotten rid of the red blood cells. We prefer that for joints and tendons. So having that flexibility is important. If your physician doesn't know how to do that, that's a problem. You're probably not dealing with an expert. They need to have that kind of flexibility in terms of changing the concentration based on your problem, changing the type of platelet prep that you have as well. It's an example of platelet-rich plasma in a gentleman, 45-year-old gentleman referred to me by a sports medicine doctor. He had persistent patellar tendinitis and was not getting better with conservative options. So in his case, we ended up using a treatment called platelet-rich plasma. And to give you a sense of what we did here, so over here, that's his kneecap. That's his patellar tendon. Over here is where the tendon is pathologic. There's some calcification in the tendon, just a sign that it's been beat up over time. So he ended up having platelet-rich plasma 2 times for his knees, had a solid response to begin with. We ended up doing a second treatment to really kind of give him a full response. And he's now back to full activity. I then saw him a few years later. Now his other leg, he developed patellar, he now had a hamstring injury. Again, we ended up treating it with PRP and he did great again. What I like about this case is that this is someone who had a tendon injury and did great with platelet-rich plasma, always a good first-line option in that kind of case. Had a great not only improvement in pain, but also returning to function, and how we could repeat treatment for that one knee to get him the best response, and how we could repeat treatment then for the other leg and get him a great response as well. This picture on the right is an ultrasound image. Again, that's the kneecap, that's the tendon. This is a zoomed in view of the needle. And what's key here is that we're injecting directly where he has his pathology and injury to the tendon. He's done great, and I expect him to continue to do well. That's been like a few years ago, and so he's doing absolutely wonderful. Next type of orthobiologic treatment to understand are stem cells. These are the main cell that drives repair after an injury. Again, please use your own cells, not somebody else's. In the United States, the only type of stem cell treatment that is legally allowed are your own bone marrow stem cells. You can use adipose if you're using it for structural support. We'll use that for sometimes tendon injuries. But the kind of enzyme that you need to use to get fat stem cells is not considered appropriate or legal by the FDA for human use. And so in the past, you probably heard a little bit more about fat stem cells being used, not as much now because the FDA is starting to crack down on that. You may have also heard about umbilical cord or amniotic fluid cells. It's been falsely marketed as stem cells in the past. The reality is that there's no living cells in that, just growth factors. And again, the FDA started to clamp down on clinics that are utilizing that and falsely claiming that that is utilized for a stem cell treatment, because that's not accurate. You may also hear about people going to other countries and using IV stem cells. There may be some utility to that for some other conditions. There's no evidence that that is actually appropriate for orthopedic conditions. I would not recommend that. For starters, the evidence of that is very limited from the medical literature. Number two, IV stem cells, like, is that appropriate? Is it safe? It's really up in the air right now. I'd be careful about that, and not legal in the United States. In terms of stem cell treatment outcomes, here's some keys to understand. If you have advanced disease, let's say an advanced knee or lower back arthritis, we can still improve your pain and function, definitely. Can we, however, improve your X-ray and MRI images, what that looks like? If you've got advanced arthritis, I can't necessarily improve how your MRI image looks. If you've got a tendon tear that's still less than 2 centimeters separated, we can improve that. I'll show some images of that. Ligament tears as well, I'll show some images of that in a moment. And if you've got swelling in the joint, we can improve that. And if you've also got what's called avascular necrosis, where the bone is starting to die, we can improve that as well. I'll show images of that as well. Can we treat bone-on-bone arthritis? This term bone-on-bone is very, unfortunately, frequently used by physicians, and it's a really, sort of ignorant way of describing what's going on. If someone's got advanced arthritis, and if you've still got full range of motion or even decent range of motion, you obviously don't have bone-on-bone, right? Like there's still some cartilage interface. And so understand that even if you've got advanced arthritis is a biologic condition. It's not just a X-ray picture on the wall. And if your range of motion and function is still intact, you can still get a very good outcome from treatment. Again, the one caveat is if you've got advanced hip arthritis. If your hip arthritis is mild to moderate, we can still treat that. If it's more advanced, it's harder to treat. you can still get a benefit, but it's just a harder joint to treat and the results are more variable. But if you have advanced arthritis, we can still improve pain and functioning. Improving what your imaging looks like is, however, unlikely. Can we treat tendon and ligament tears? Simple answer is yes. If you've got a partial thickness tear, definitely. If you've got a full thickness tear, sometimes we can. And here's an example. So this is a case study of a gentleman. This is a regular person. He's a butcher. He injured his ACL playing recreational volleyball. I saw him a couple months later. We treated him with his own bone marrow stem cells. 3 months later, doing great. We started dynamic activity. And I'll show you some images. He's still doing great, but I'll show you some images of what that looks like as well. This picture on the right is an X-ray image of an ACL treatment. That's the kneecap. That's the thigh bone. That's the shin bone. This is the needle. And what's lighting up here is the ACL. You can only do this kind of injection under really high-level X-ray guidance. Cannot do it with ultrasound guidance. Cannot do it blindly. This is how we know if we're in the right spot or not. So let me just show you what his results were. So he had a great pain relief and functional improvement. He's back to his normal activities, no pain. He's doing wonderful. What's exciting is what his MRI looks like. So MRI on the left is before his treatment. That's the kneecap. That's the femur. That's the tibia. That's the ACL. You can see the ACL at the bottom. As you go further up, it starts getting very hazy and disorganized. The radiologist has read this as likely a full thickness tear. And this now is his MRI 3 months later after treatment. Kneecap, femur, tibia. Here's the ACL now. What you see now is a very clear linear structure, really quite well delineated. What's nice about this is this essentially has been read by the radiologist as this is now a normal-looking ACL. It's got a little bit of fluid still around it, but this is essentially a normal-looking ACL, which is incredibly exciting. This is a rotator cuff tear. This is a patient of mine. He is a general contractor, does a lot of overhead work, and came to me with a rotator cuff injury. Again, treated with his own bone marrow stem cells, doing great post-treatment, but these are his images. So this is, on the left side are some ultrasound images. This is the rotator cuff. This black space is the hole in the rotator cuff. That's a full thickness tear. Same thing down here. Full thickness tear, it's less than 2 centimeters in length, retraction. And this is him 3 months later. Normal rotator cuff, this is healing rotator cuff, right? That big sort of hole in the middle of the rotator cuff is now gone. And what you have now is healing tissue. He's done great clinically in terms of getting back to work, no pain, exercising, and his images look fantastic as well. Actually, before I go on, let me just catch up on some questions here. Thank you for sending those in. Okay, somebody asking very specific about treating cervical spine or neck issues. I do not treat cervical spine issues. I would defer that to a colleague. They're then asking more specifically about a very specific type of neck problem, craniocervical instability. There's really only a few people who are really trained to do that. And, I would stick with the people who have that kind of proper training for that. Somebody else asking about hip piriformis. Can that be treated? Absolutely. Is it resistant to the process due to hip area? No. So if you have a soft tissue issue around the hip, let's say tendinitis or piriformis kind of strain, absolutely, that can still be treated. If you've got mild to moderate arthritis, that can still be treated. If you've got more advanced arthritis, it's just that the results are more variable. So we can say for most areas, like if I tell you for a if you've got mild hip arthritis, I think your chance of getting 70% or higher is still very good. That's reasonable. If you've got more advanced hip arthritis, your chance of getting more than 50% improvement is probably a 1 out of 3 chance. And in those cases, we generally refer people for hip replacement. For patients that want to avoid surgery and still proceed with treatment, they'll still get some degree of pain relief. It's just that it's very variable in terms of how much pain relief. But for what you're describing, a hip piriformis issue, absolutely that can still be treated. You treat inflammation from tendon tear prior to doing PRP treatment. Great question. So I would recommend avoiding, so the way, it depends on what you mean by treating inflammation, right? If you mean by injecting a high dose of steroid into the tendon, I would not recommend that. And the reason why is because steroids in a high dosage can actually damage tissue. And if you've already got a tear in the tendon, you really don't want to be tearing it more. You don't want to be weakening the tissue more. So you can use a very low dose of a steroid injection, where it's 1/1,000,000th the dosage. That's safe to use, but I would recommend avoiding a high dose. Okay, somebody else asking about plantar fasciitis. Surgery years ago, still painful? Yes, absolutely. Like we treat plantar fasciitis also all the time. Another question to ask is your pain coming from the plantar fascia or is it coming from a nerve? Let's say pinch at the ankle or at the lower back. So still, all those are very treatable. Okay, just a few more questions here. Just answer that. Somebody asking about chiropractic evaluation for their back pain. Is this the first good step along with imaging before physical therapy and PRP? Yeah, I mean, what I generally recommend is, look, if you've got lower back pain, conservative treatment always first line. Let's say whether that's chiropractic or physical therapy, always start that first. If you get better with just that, wonderful, then stick with that. But if you're not getting better with only that, then getting some imaging and then considering additional treatment options such as PRP certainly makes sense. Okay, somebody asking about they've had stem cell treatment for their knee 5 years ago. They're starting to wear off. Can it be done again? Absolutely. The evidence that we have for repeat treatment is that people tend to respond very well. What that means is, generally speaking, after treatment, there's kind of a slow but progressive improvement for several months. And generally, people are staying at that level then longer term. If you have sort of a decline in that, then repeating treatment at that point, you're now starting at that higher level and you're kind of building to that, you're kind of stair stepping to a higher level after that. So definitely repeating treatment certainly makes sense. Some of our best outcomes have been in patients where we've actually done like a repeat treatment. Somebody asked about a bulging disc at the L3, L4 level. Absolutely. We see that all the time. If you've got degenerative disc disease or a disc problem or wear and tear in the lower back, those are all very treatable. The keys there are to treat every level where there's pathology, and that generally gives people a good result. Okay, a lot of questions coming. So someone else asking about treating arthritis in the fingers. Can it reduce the pain and the inflammation? I'd like to know what's causing the pain. If you've got wear and tear arthritis, certainly. If you've got, let's say, rheumatoid arthritis, depends on what we're talking about. If you've got, let's say, rheumatoid arthritis, you're on medication, it's under good control, but you've got 1 or 2 joints that are still a little bit achy or painful, then absolutely we can still treat that. If you've got full-blown rheumatoid arthritis where you've got like 30, 40 joints that are involved, I would recommend getting that treated more traditionally before jumping to something like this. Somebody else asking about their cyclist, 2 steroid injections for hip bursitis. They're doing PT, they're still having pain. Absolutely, regenerative medicine can still be helpful. In my experience, hip bursitis, it's not just a bursa problem. It may be a tendon problem. It may also be coming from the back. And you want to make sure you're treating that fully and comprehensively. But Regen Med is fantastic in that kind of case, for sure. All right, someone else asking about they're overweight, asking about orthobiologics. It can still work, but I think the way you want to handle it is you want to treat both the weight issue as well as the structural issue at the same time. So I think if you take somebody and you treat them in isolation, like if you only treat their one problem, you don't treat everything, it's a mistake. Now, let's say you're someone who's been exercising, but now you're having problems exercising because you've got a knee or a back problem or an ankle problem, then absolutely treat that problem, get you back to exercising. On the other hand, let's say you can't exercise at all. You've got some metabolic issues as well because of the obesity, then treating that makes sense. As an example, we have patients where something else that we do separate from the regenerative medicine aspect of things is a weight loss program where we'll use semaglutide to help with weight loss. If that helps with the weight loss, helps with your metabolic health, you're still having issues, then you're also then treating with Regen Med some of the joint or tendon issues. That's a really great combination way to treat this. All right, somebody else asking about Regenix. Right, so Regenix, it's a company based out of Colorado. There's a Regenix network where we are affiliated clinics. We're separate from Regenix, but we are affiliated with Regenix, where we utilize their protocols for lab prep, for treatment, following results together, following best practices. And so it's a network of practitioners. It's not a specific treatment, it's a network of practitioners. Potential side effects of treatment. Yeah, so great question. So with PRP and bone marrow stem cells. So from the data that's available, from my own experience, from the data from the Regenix network, and from peer review research, these are relatively low-risk treatments. There's no such thing as no risk. Anytime you stick a needle into the body, there's a low but potential risk for infection, bleeding, tissue damage, and no response. How do you minimize those? So use standard sterile protocols to make sure you minimize or eliminate the chance of risk. Utilize image guidance to make sure you're hitting the right tissue, not hitting something that you shouldn't be injecting. And then picking the right candidates, right? Meaning, like, if you have, let's say you're dealing with cancer, leukemia, you're on chemotherapy. I don't think utilizing platelets or stem cells at that moment makes a lot of sense. Prolotherapy might make sense. That's a different way of doing some of these treatments, using only sugar water or dextrose, mainly because you're gonna get the effectiveness of the platelets and stem cells may be washed out a bit if you're on chemotherapy. So, like, being thoughtful about how you utilize these treatments makes sense for sure. All right, somebody else asking about being on high-dose prednisone. Does that affect treatment? Yeah, I mean, ideally, you would not be on the prednisone. Ideally, you'd be on no medication before treatment. Now, the reality is that most of the people that we treat are on some kind of treatment. So we try to get people to minimize the meds that are not necessary. But if they're on some meds that are necessary, then you still go into it with your eyes wide open. That may limit the effectiveness of treatment. So what that means is, as an example, so I mean, we see a lot of patients with autoimmune conditions because of the rheumatology background that I have. And, we may have patients that are on biologic agents for their rheumatoid arthritis, psoriatic arthritis, or other autoimmune issues. In my experience and an experience in the literature, that does not seem to make a difference in terms of their effective treatment. With that said, let's say you're taking high doses of prednisone recently. That's the one where I would say, look, try to get that dose to a more reasonable dose. And then if you can't get off the treatment just because you need that for your overall autoimmune issue, then proceeding with treatment makes sense. So let's say you're on 40 milligrams of prednisone. That's extremely high, right? Like, you probably need to wean that down. I do have cases of patients where they've been on 5 or 10 milligrams of prednisone long-term. They just can't get off of that, and they've done fine with treatment. But if you're on like a super high dosage, I would recommend trying to wean that down before actually proceeding with treatment. Somebody else asking about shockwave treatment. Shockwave treatment works because it helps to bring more blood flow. I think there's value to it. It's low risk. There's some data on it being effective as well. I think as a complementary treatment, it's probably helpful. But it's a different kind of treatment, but I think it's helpful. Is it a form of regenerative medicine? I think it's complementary, right? In the sense that it brings blood flow. That could be similar to, let's say, massage, scraping, dry needling, things that bring blood flow as well. So I think it's similar that way. I think of it as separate than, let's say, what we're doing when you're talking about injecting platelets or bone marrow cells directly into tissue that's been damaged. Somebody else asking about involuntary hand movements. Can this person be a good candidate for PRP injections? We need to know what's causing that. If you have a pinched nerve that's causing some muscle twitching, possibly. If you have something like Parkinson's or something like that, then that's a separate issue. I would not recommend these kind of treatments in that case. Okay, great. Very good questions. Thank you. Let's get back. So interventional orthopedics is the concept of utilizing image guidance to treat orthopedic injuries. So a few pictures here. So Picture on the left is a ultrasound image of injecting into a rotator cuff. So this tissue right there is the rotator cuff. That's a normal rotator cuff. So a little gap right here, that is a tear in the rotator cuff, and that's a needle going in. This is a zoomed in view. That size tear is less than 1 centimeter. Important to understand that if you want to inject that, if you're doing it blindly, you're not going to hit that 1 centimeter by 1 centimeter kind of tissue. Very hard to do that blindly. Under ultrasound guidance, so much more doable with some skill involved, but very doable. Picture on the right, nice picture of injecting another shoulder under x-ray guidance into the joint and the labrum. So shoulder is a ball and socket joint. This is the needle. This sort of curved line here, that is a little bit of contrast into the joint. That's how we know injecting cells directly into the joint, we're being accurate. So the triangular structure here is the labrum. They also had a labral tear, and we're injecting into the labrum as well. Injecting the labrum blindly, almost impossible. I mean, essentially impossible. But injecting it under X-ray guidance, very doable, and gives you a better result. I showed these pictures before. The picture on the left was injecting under ultrasound guidance into patellar tendinitis. Picture on the right, injecting an ACL tear. Again, both of these are doable with ultrasound guidance or image guidance or X-ray guidance, not doable under just blind injecting. This is a case study of injecting someone's ankle who's got avascular necrosis. It's a 41-year-old man. He's a chef. He's got avascular necrosis as well as early osteoarthritis. This is a guy who stands for like 12, 13 hours per day at work, right? So obviously being able to tolerate that weight on his ankle is important. We injected his own bone marrow stem cells. The picture on the left, so he's doing great from a functional and pain standpoint. His images are really exciting as well. So this is on the left side, that is the ankle joint. It's got a little bit of fluid there. What you see in the bone is that he's got swelling in the bone. And this has been read out as avascular necrosis. We're catching this at an early stage where the bone hasn't collapsed. 3 months later, his MRI, the fluid is gone, and the swelling of the bone is gone as well. That's a great result, right? That's someone whose avascular necrosis has been not only treated, but really essentially has been put into remission. Regenerative medicine treatments offer safe and effective solutions for pain. Okay, let's catch up on some more questions. So what is our approach with helping patients who are not comfortable with injections? Great question. So sedation is always an option, right? Taking some Valium is an option, but IV sedation is an option. We do that in the office as well. Has to be coordinated with anesthesia, but that is definitely an option for people who are more nervous about that. Somebody asked about getting umbilical cord treatment for their left knee. They're getting better. Had a few falls. Okay, they've had some imaging done. They've got some torn meniscus, Baker cyst, received PT, going to pool. Okay, it's not really a question, but this is someone who's had a knee issue in the past. It sounds like knee arthritis. They've had an umbilical cord injection. If this was done in the United States, there's no living cells in that. They had a growth factor injection. Probably no different or better than using your own blood platelets. I'd always recommend that first line rather than umbilical cord injection. Looks like they've had another injury. They've got some more issues now. They're starting physical therapy. Yeah, see what happens with physical therapy. Hopefully you get better. If not, then consider getting treatment with your own blood platelets or bone marrow stem cells. Okay, great question. Somebody asking about osteoarthritis in the thumb area. Absolutely. As a rheumatologist, I tend to see a lot of people who've got hand issues. It's just kind of part of my practice. I see a lot of hand issues. And using ultrasound guidance, we've had great results with both platelets and bone marrow for treating thumb arthritis. Absolutely. Good question. All right. What is the procedure for extraction of stem cells from the body? Great question. So in an adult individual, the way that you're able to get the most reliable concentration of stem cells comes from your own bone marrow, and it comes from the back of your pelvis. I know people who will do bone marrow aspirations from the tibia or the shin bone. If you were 8 years old, that would be a fine place to get a reliable concentration of stem cells. If you're an adult, I only really treat adults, then that is not the right place to get it. You should get it from the back of the iliac crest or the back of the pelvic bone. You don't need to be sedated for that. You can if you want to be, but like it's not necessary. Normally, just using a lot of local anesthetic is adequate. And if your physician and practitioner are skilled and adept at this, that should be adequate to do this properly. Somebody asking, are you the only doctor who does this? Will insurance cover this? What are the next steps? Okay, lots of questions there. So obviously there are other doctors in the world who do these kind of treatments. At Chicago Arthritis, I'm currently the only physician doing this. Insurance, there are some self-insured companies, that's most large companies, that will cover this, but I'll talk a little bit about what are costs if it's not covered. Next steps of getting treatment, you just have to be evaluated. And we'll give you that information in a moment as well. You can go to the website, but we'll give you some more direct ways as well. If you've had stem cell treatment, can't afford it again, will PRP the next option? PRP is a great option in that case. Obviously, wherever you're getting treatment, make sure you ask them about payment plans as well. That's always an option as well. Great questions. Again, if you want to stay in contact with us after this webinar, please go to chicagoarthritis.com. Actually, I mentioned in the chat section as well in the beginning that if you'd like to schedule an appointment with us or to be evaluated, 3 different ways. You can schedule with us directly online, you can email us, or you can also just go through the website, and we'll put that in at the end of the chat or end of this talk as well. So is this too good to be true? There's evidence from Philip Hernigue since the 1990s. He's a French orthopedic surgeon where he's been doing this in shoulders and knees. The Regenerative Network has data since 2005. My own personal experience is since 2008. What's interesting is I have colleagues who 10 years ago would tell their patients, hey, there's no evidence this works. That's not accurate. There was evidence back then. Obviously, in 10 years since then, there's a lot more evidence. Some of those colleagues will now tell their patients, yeah, they think it works, but they're not sure how well it works. You know, this is a rapidly developing field, but it's not new, right? There's definitely right and wrong ways to do it. There's evidence for over a couple decades now. You should have your expectations grounded in reality and evidence-based medicine. You know, your physician should give you a realistic expectation. That means not pie in the sky, but also means not like a doomsday expectation, right? Like there should be an appropriate experience based on not only peer-reviewed literature, but also on their own years of experience of what is realistic, of what you can have, of what you can achieve. How long do results last? Again, there's data from the Regenerative Network that goes over 10 years. Philip Hernigue has data that goes over 20 years. What I tell people is always think conservatively. If you have a chronic condition, expect a repeat treatment at some point. So as an example, if you've had a stem cell treatment and you've done well for 5-7 years, you may need a repeat or you may need a booster treatment at some point. That's very helpful. If you've had a platelet treatment, you may need a booster treatment after a couple of years. Again, depends on the issue and the person, but you know, be conservative in your expectations. Understand that if treatment gives you good relief, good functionality, good stability, make sure you're doing all the right exercises, make sure you're doing all the right supplements, make sure you're aiming for an ideal body weight as well. Again, we have a physician-assisted weight loss program that's very helpful for these kind of things, improve your metabolic health as well. Do everything that you can do to put you in the best scenario for getting the best outcome long-term. In terms of costs, not routinely covered by insurance. Regenix Corporate now does have a couple thousand companies that have now added this to their benefits plan. If you're interested in learning more about that, go to regenixcorporate.com. In that case, it's covered like any other insurance benefit. If you're doing this out of pocket, here's some expectations of what costs would be. Prolotherapy, about $700, PRP, $2,500 plus, stem cells, $7,000 plus. Those are realistic expectations for what the costs are in the United States. Keys to determine value. Is your physician, clinic, or regenerative medicine expert? Make sure you're seeing someone who's an expert, not someone who's dabbling. Are you receiving a real stem cell treatment or something that's mislabeled like amniotic or umbilical cord fluid? This is an in-office procedure. You can avoid hospital and surgery center facility fees, which really drive up the cost as well. We talked a little bit about what makes a regenerative medicine expert, a lot of different things. The point is, if you're properly professionalized in this, you do every single one of these things correctly. That's what you want in your physician as well. A little bit about how we do things at Chicago Arthritis and Regenerative Medicine. We're focused only on musculoskeletal issues, non-surgical treatment of musculoskeletal issues, evaluate you for inflammation, instability, asymmetry, neuromuscular issues. Try to correct with low-risk interventions to begin with. If not working, then escalating appropriately to the right kind of treatment. It's a regenerative medicine treatment using the best possible treatments that are available, your own cells, in a manner that is really dictated for what is ideal for you and proper for you, and delivering those cells using the best level of image guidance possible. How to get evaluated. Mentioned that a little bit before, but we'll kind of list that again in the chat section. You can get evaluated 3 different ways. You can just go to chicagoarthritis.com. Actually 4 ways then. You can call us directly. That number is listed there. There's an email address. And we actually have our direct, you can schedule directly into our schedule just by with the link there as well. More questions. All right, folks are very talkative today. So we are located in the West Loop downtown, not located in the suburbs at this time. We are hoping to get a satellite office in the suburbs eventually, but currently we're located just in the city. You're welcome. Appreciate everyone's time. Thank you for the thanks and compliments. How many treatments does it typically take when treating arthritis in the hand to get relief? My general recommendation for any of these treatments, any body part, is that if you're using blood platelets or bone marrow, all right, if you're using prolotherapy, meaning dextrose, prolotherapy, sugar water, my recommendation is, look, it's going to probably take a few treatments to get relief with dextrose. But if you're using blood platelets or bone marrow, what I recommend is get treatment on day 1. You'll have more inflammation for the first 2-3 days, stiffness for about a week or so, kind of back to baseline after that, kind of bouncing up and down for the first couple of weeks. You should be having improvement at around the 3 to 4 week mark, and then progressively better for the next few months. All right. For platelets, that improvement will be for the next 3 to 6 months. Then we'll have a better sense for, are you at your goal or not? When you start to sort of hit your peak or kind of plateau in terms of response, if you're satisfied with your outcome, great. If you're a little bit below where you need to be, let's say you're 50% better and you're 6 months out and you're trying to get to 80% better, well, then we'd repeat treatment then. That's for platelets. For stem cells, you should be improving for the next 6 to 12 months after treatment, all right? And then maintaining that for a few years. Again, if you're improving, and you start to plateau, at that point we decide, do we just do a booster platelet treatment, or do we do a repeat stem cell treatment? If you're at within the first year, normally I'd recommend just a booster platelet treatment. If it's been a few years, then we consider maybe doing a repeat stem cell treatment. Wonderful. Well, listen, guys, we are at the end of our time today. I appreciate everyone's time, everyone's patience. Very grateful for this time to be able to talk and educate and just sort of converse with everyone. Always nice. If you have further questions, everyone's always got further questions after this is over. Number 1, you'll get a link for watching this again. You can watch this again. You can share it with friends or family members. In addition, we are here to answer questions. So email us, call us at your leisure, and we're here to help. And if we can help directly as well with any of your issues, grateful to have that opportunity. And until we meet again, everyone, thank you very much. Have a good day and live well. Bye-bye.